All right. Hi, everyone. My name is Lucy. I am a graduate student at Dr. Christine Allen's lab, and today I'll just be presenting a little bit of my research project entitled Parp Inhibitor Drug Combinations and the Six Rights. So this is just to acknowledge everybody who was involved in supporting my research. So we start off with this slide about the six rights of medication administration, just to give everyone a background. So my background is I'm a pharmacist by trade, and in pharmacy school, this is kind of grilled into our heads that, before you administer any medication to anybody, you have to check for the six rights. So it has to be the right person, right medication, right dose, right time, right route, and right documentation. And the reason I come to this is to kind of let everyone kind of have an idea as to how my mind works when I go through my research project. And I work on ovarian cancer. So ovarian cancer is the 5th leading cause of cancer-related deaths among women. And although this figure is a little bit outdated, stating statistics between 2011 to 2015, there actually hasn't been much improvement in ovarian cancer prognosis, mainly because ovarian cancer is very difficult to diagnose. So when patients come to the clinic, they actually already have very late stage disease. So it's harder for us to treat those patients at that point in time. And another interesting fact about ovarian cancer is that the majority of ovarian cancer tumors actually present with some sort of double-stranded DNA repair mechanism deficiency. And this is through either a mutation, gene deletion, or promoter hypermethylation of any of the genes that are involved in the homologous recombination double-stranded DNA repair process. And as you can see, there's a lot of genes in there. There's actually far more than what I've listed, but I have highlighted the top one, which is BRCA1 and BRCA2, mainly because that's the gene. Those are the genes of interest for my particular paper. And the reason that I decided to focus on that is because the PARP inhibitors, being a class of drugs that are already used in the clinic for treatment of ovarian cancer patients in the maintenance setting, actually take advantage of these double-stranded DNA repair deficiencies, particularly BRCA1 and BRCA2 mutations or deletions. And so what are PARP inhibitors? Well, PARP inhibitors inhibit PARP, and they inhibit the reparation of single-stranded DNA breaks. Those single-stranded DNA breaks then turn into deleterious double-stranded DNA breaks. And in the tumor cells that cannot undergo double-stranded DNA break repair, they will then die and elicit synthetic lethality. And so typically when a patient comes into the clinic, they undergo debulking surgery and staging. Then they undergo adjuvant chemotherapy before being placed on a maintenance therapy in the form of the PARP inhibitors. So the PARP inhibitors have actually had quite a bit of success over the years. They end up essentially delaying disease progression and delaying a disease recurrence. However, this doesn't stop recurrence. Most patients will actually have their cancer come back. And that's kind of the space that I chose to work in. So that's, to me, a population of patients that are underserved. And so I decided to kind of target that population of patients. And the route that I decided to go towards is to use combination therapy. And it's actually been a very hot topic, using PARP inhibitor drugs in combination with traditional chemotherapies to improve or maintain efficacy or bring back that sort of sensitivity to chemotoxics in those patients while reducing toxicity. And the reason I have this left side picture here is because this idea of administering combination therapies, although it's been around for a very, very long time, it's recently gained traction, the idea of administering combination therapies at a synergistic ratio. So essentially pre-testing your combination on a wide variety of cell lines in your disease state and looking at spots where, you know, the molar ratio or the mixture of one drug to another, how much of one drug to another is going to elicit a synergistic effect and thus, you know, maintain or improve efficacy and reduce toxicity. And this concept has been used and tried and true with the product of Vyxeos, which combines daunorubicin and cytarabine in a synergistic ratio to be delivered for the treatment of acute myeloid leukemia. So using that premise, I decided to look at niraparib and doxorubicin specifically and to find areas in which they would be synergistic. And to determine synergism, I decided to use the Chow and Tilali method of determining synergy. So essentially, I look at the toxicity of drug 1, niraparib, and drug 2, doxorubicin, either as monotherapy or in combination at varying different molar ratios. I plug them into this equation to look for a combination index value. Values less than 0.9 I deem as synergistic, between 0.9 and 1.1 additive, and greater than 1.1 would be antagonistic. And that's exactly what I did in a panel of ovarian cancer cell lines. And what I found is that when I combine niraparib and dox in a 10:1 molar ratio, I typically get this area of green, so this area of synergy. However, instead of presenting on the successes of my research today, I actually really wanted to present a little bit of my failures. So I wanted to kind of zoom in on these two cell lines, PO1 and PO4, just because I found some very interesting results with these two cell lines. And the reason I say that they're interesting is because PO1 and PO4 are actually paired cell lines. So they're cell lines that are derived from the same patient, except from a tumor that was taken at different stages of her disease. So PO1 was taken at a primary resection when the patient has only gotten like one bout of chemotherapy, and PO4 taken later on when the patient had her disease unfortunately recur. And so these two are essentially pairs. And what I found is that across all of the ratios of niraparib to doxorubicin, I found that in the PO1 cell line, the combination index values were lower, consistently lower than in the PO4 cell line. And the reason I thought that this was interesting was because, well, I got to thinking, what was different between these two cell lines, given that everything else essentially is the same? And looking into the literature as to what their mutations are, I found that the only mutational difference between PO1 and 4 is that PO4 actually has a reversion of the BRCA2 mutation. So the BRCA2 mutation that was present before reverted back to wild type. Digging more into the literature, I found that this BRCA reversion phenomenon was a known mechanism of treatment resistance. This is just data from this one paper in the Journal of Clinical Oncology that looked at 2 patients, and it looked at BRCA expression both in the primary tumor and then at a secondary resection, essentially PO1 versus PO4. And they found that many of those patients exhibited a reversion of the BRCA genes, whether BRCA1 or BRCA2. And getting really, really curious, I decided to look at previous work done in our group with another Parp inhibitor called olaparib with doxorubicin as a combination. And lo and behold, in the PO1 and PO4 cell lines, you consistently see this increase in combination index values. And so what does this tell me? This tells me that perhaps this combination isn't actually very suitable for patients that have resistant disease or patients that have disease that has recurred already. And what's really fascinating to me is that, so for the Parp inhibitor niraparib, the parent company Tessero actually did while during clinical trials, they actually did some combination trials between niraparib and pegylated liposomal doxorubicin. And that clinical trial has since been terminated. We can't really say too much about what has happened because they didn't really show any data. However, given that this combination isn't really in the clinic, one can just kind of hypothesize as to perhaps that the results perhaps weren't as great. But what was interesting to me was that they did this trial in platinum resistant ovarian cancer patients. So they specifically treated this subset of patients who may have more likely have had these BRCA reversions or may have had other mutations that would specifically make them less suitable for this treatment in the first place. And so that was something super interesting to me. And so we go back to this 6 rights idea. So I kind of amended the 6 rights of medication administration to look like more like this, the 6 rights of drug combination administration. So for me, the food for thought in this, or the conclusion of this, is that when it comes to drug combinations, you have to really look at what combination for what person, for what patient group, who are we treating at the end of the day, and really kind of screen for a whole bunch of cell lines that will have, varying mutations and varying characteristics. And then in the future, look at, who those patients are, or what this therapy or what this combination is suitable for treating. So thank you very much for your attention, and I'm open to questions.
Thank you very much, Lucy. So I'll let everyone take a moment to type their questions, and I will ask one in the meantime. Do you see this as a problem, or as a common problem, not choosing the right patient population for the new therapies?
I see this, I don't know how common this problem is, but I see this as something that's very plausible to happen. Mainly because clinical trials happen within years, right? And sometimes they happen at different sites. Sometimes you're struggling to find patients that are going to enroll in your study, or struggling to find a very particular subset of patients. So I can imagine this being an issue. So of where we don't have enough patients to trial these in anyway. So then it would be a primary limitation to finding the right patient subset, essentially.
Great, thank you. Marshall, are there any questions or hands?
There's a question indeed, again from Diana, who comments and asks, thanks for a great talk. What should change as a result of your findings in terms of treatment and patient communication at the point of care?
That's a really good question. I think what should change is we should definitely do more of these wide pre-screenings, these very, very high throughput screenings, recognizing that the cell lines themselves aren't a perfect representation, but using them more as a tool to identify specific gene mutations or specific disease characteristics that will make perhaps this treatment modality good for patients A versus patients B. And recognizing also that, so even though patients A might be a very small group of patients, they're still very worthy of being treated. And your, your compound, which might not be hitting everybody, right? It's still very important to be mindful of those things.